Wow.
Okay, good, good. We're
Okay.
recording.
Yeah,
Okay.
right.
So, for a little introduction, this is going to be uh, a demonstration of how we use DNA. And instead of me being the teacher, Alan is going to be the teacher, and I'm going to be the patient, which is kind of a fun little switch. Um, so, I'm going to start with why am I the patient? So I'm having a challenge with my right knee. Um, and the right side of my body has had multiple challenges over the years. Um, in 1985, I took a long fall rock climbing and broke my talus. And I was a case study for Stanford for my recovery of that injury. Interestingly, I developed a bone spur about 10 years later at the top of my tibia that I believe is related to um, uh, the forces on the periosteum on the tibia related to the talus injury. Um, 28 months ago, I was in a pretty severe motorcycle accident where I got ejected from my motorcycle and I landed on my femur, on the lateral edge of my femur, and I had a compression fracture in my trochanter. Um, because of the density of my bone structure and my periosteum, it wasn't a fragmented fracture, and so I didn't need any intervention. However, the forces of that accident created a lateral whip on my knee as the iliotibial band absorbed energy. That was the setup for my knee challenge right there. Okay. Last summer, I was on a mountaineering expedition in North America, and it happened to be the one of the most arduous approaches in North America. I went to go climb the Grand Teton. And at about mile 6, I took a bad step and I sprained my posterior cruciate. And my knee has not been the same since. I barely got off the mountain. It was brutal. It was one of the most painful things to get off that mountain. Um, and so there was lots of rest and regeneration. Um, but it's still not right. I have pain in the anterior horn of the knee, the meniscus, where the most density of pain receptors are, nociceptors. Um, and so I've done some work on myself, and I make limited improvement. And some of it is because when we try to be our own patient, sometimes we get in our own way. And so we have to turn it over for someone to have eyes to be able to see what we can't see. So the movements in my knee that are painful, compression, shock absorption, external tibia rotation, like as in the talus flossing, and a Polican squat. Are you familiar, Alan, what a Polican squat is? It's when you have your foot at an angle and you're stepping down. And so those are the like
Okay.
the those are the three main things that are creating a challenge for my system. And so currently I can hike about 2 miles before I start having distress. And so my capacity has been severely limited from this. And that's what I've got so far. And so now I'm gonna let you take it over, Alan, and you can describe the process of how you want to proceed. And I'm going to get out of the way and allow you to be the facilitator.
Right. All right. So thank you. Also, thank you for your history. Yeah, that wasn't a good knee injury. It looks like it was a bit serious for you. And are you able to hear me?
I can hear.
Yeah, definitely. So, how long? When did this happen?
What is this?
Yeah,
You mean
like when? When did this happen?
last summer when I dislocated the knee or when I sprained it? That was August of 2025.
Oh, okay. All right.
And,
That's
and,
okay.
and the
So,
motorcycle accident was January of 2023.
okay. All right.
Oh no,
So,
excuse me, January of 2024. And the Talus was
right.
1985.
Yeah, right. Okay, so I'm going to check out some of the knee movements. Basically, I will start with the basic knee movements. Check is it the right or the left?
Right.
Right. Yeah. Right. Okay. Right knee. So I will assess knee flexion, extension, rotation. Yeah, that's the local knee movements. And then I also check out the movements you've described. Yeah, where you feel discomfort. That squat
Yes.
plus all the other movements where you feel discomfort. So I will check out those ones and then
Okay.
see, yeah, what's going on with this. Okay,
And
all right,
so
but first,
and so when you say check out, um, you're talking about doing an assessment and also creating a map. You want to say a little bit more
yeah,
about
definitely.
what that means?
Yeah, definitely. So I'll use those movements as my stem into your nervous system, and then see how we're going from there. So as I develop my map, be describing. So what we want is first to establish our nervous system response, and then since it's a remote call, I want to see if my nervous system is able to connect with your nervous system. Yeah, so basically, I'll first try to establish my indicator. Yeah, so if it's like, for me, I like using show me yes, show me no, skin, I pinch my skin, yeah, skin receptor, show me yes, show me no. Right, I think I'm okay.
I'm going to
Then I
check
want to ask,
myself. Do you want me to check
yeah,
me
right.
myself, or do you want to or do we not want to worry about it?
So so I'm imagining you're someone who doesn't know anything about the process.
Perfect. Perfect. Okay, I'm going to take off my glasses, and
Yeah.
I'm going to park my thinking brain over here so that I'm out of the way.
Yeah, right. So after establishing my own indicator, I think I'm clear. Good, that's okay. So I love to ask if there's permission for my nervous system to connect with your nervous system. And then I check my indicator. Right. I'm getting a yes. So for those who are on the video, so if I slide, this is my yes and this is my no on my own self indicator here.
That's
So,
probably hard for people to see, but that's okay.
Yes.
That's probably hard for people to see but that's okay. And it's only because of the angle of your hand. If you turned your hand this way, right, you've got your hand this way and it's hard to see. But if you turn your hand this way, then people can see it.
Like, something like this.
Yeah. Then people can see.
Yeah, so I'm like, show me yes, show me no. So this is show me yes, this is show me no. So this is like a yes for me, this is like a no for me.
Oh, okay. Good.
Yeah.
This is important to know that people's yeses and nos in their indicator will appear different than our own. But that doesn't matter because what matters is the consistency within the practitioner.
Yeah. All right. Yeah. So I ask for permission. Before I start, I have to ask for permission for me to is there permission for me to start assessing and then start treating, working with the Java system? So I check my indicator. Right, we are good. That is a yes, good, right. So having established this, with my flowers getting in the way right here. Okay, that's okay. Having established my indicator well, and then feeding this connection, using limbic resonance with Joseph, I want to start assessing, starting with the basic knee movements. So I will start with Joseph. Are you able to bring your knee into extension? Yeah, that is like straight knee. Okay, all right. After him bringing the knee into...
What I feel is a little bit on the anterior horn and it doesn't feel like I get to full extension. Like there's a few degrees that I'm missing to get to full extension.
Right.
And that might not show up in the video.
Oh, okay.
Can you see it?
Yeah.
It's maybe 3 to 5 degrees.
Yeah, definitely. So, do you feel discomfort when you bring your knee into extension? Something on anterior horn you described?
Yeah, it feels like an inflammation response is holding it from going to full extension.
Okay. All right. So that's the extension. Let me check my indicator response here. This is no. That's I feel a no on my indicator response. So if we look at nervous system response, this would be like a hypertonic response, right?
Yes, it's in the hypertonic zone. If you know, is it
yes?
Is it a locked no or is it just a no?
Yes, come again.
Is it a locked no or is it just a no?
Yeah, I feel it's a locked no.
Okay, so that's full hypertonic.
Yeah, so that was hypertonic, and then if it's hypertonic, that's my indicator response. I now find the correlation. Is this is this a limbic problem? Is this a physiological problem? Is it a structure problem? So using my indicator here, so is this a limbic problem? Is this a physiological problem? Is this a structural problem? Right. So I'm getting a structural problem. with your knee extension.
Okay. So we're
Yeah,
at,
let's proceed on it.
so extension in the clear is structural. Hypertrophy.
Yes, I'm getting this. Yeah, a structure problem right there.
Yep.
Good. Now, so if I'm developing my map, I can write somewhere knee, right knee extension, indicator response, hypertonic, correlation, structure, and I leave it there. I come back to collect some more information about his knee. Right. So now let's have Joseph do knee flexion. Yeah, right. How is that? How do you feel that movement?
At the closed position, the hamstrings feel like they want to cramp. There's no pain.
Cramping in the hamstrings. Right, okay. So now let's come and find our indicator response. Still, I find it locked. Hypertonic. Is this limbic, physiology, structure? Right. Right knee flexion, structure response, structure correlation.
Okay.
Good. Let's proceed and see. So those are the first two knee movements I've seen. Now, actually, people normally forget about knee rotation. I think it's mainly flexion and extension that people know, but rotation, many people don't really check out knee rotation. But the knee also has a rotary component. So let's have Joseph. Do you have a mat?
Yes.
Yeah, yeah.
Are we doing kneeling rotation?
Yeah, rotation. If coming to half kneeling. Yeah, so half kneeling, you're going to lift your heel and then keep your foot on the ball of the foot. So you're going to keep the ball of the foot down. You're going to stabilize your femur with your hands, with your hands. So your femur doesn't shift side to side, and then you want to shift your heel side to side. Yeah, establishing this rotation, internal rotation, external rotation, internal rotation, external rotation. Right. How do you feel with this movement?
No discomfort. It feels like I have full range of motion.
No discomfort.
No discomfort. Feels normal.
Right. Okay. So let me check my indicator response with this one. I still I'm getting nervous system is still not normally responsive with this one also. Even though there's no discomfort, but I'm still getting nervous system not normally responsive.
Sure.
Hypertonic, yeah. So let's check, is this limbic, physiology, structure? So if you can see my my indicator right here. So with this one, it is limbic, physiology, structure. Okay, all right, that's okay. Still I'm getting a structure response there.
Okay.
Correlation, yeah, correlation. I'm still getting a structure with this one.
So structure. Yep.
Yeah, good. Now, knee flexion, extension, and rotation are the major knee movements local to the knee that I've assessed. Now, I'm going to have Joseph do the movements where he feels the discomfort. So I'm noting down knee flexion plus indicator response plus its correlation. Knee extension, indicator response, correlation. And knee rotation, my indicator response, correlation. I'm noting down all these details. as I'm developing a map with them. Okay, right? Are we okay?
Are we at external talus? Because that was the one that's
Yes.
really shows up for
Yes.
me in rotation. When I come to
Yes.
externally rotating the talus, I feel what's occurring in the lateral horn here, or the anterior horn, rather
Oh,
than
okay.
so this is when I feel tibia rotation as a problem. When my knee is in flexion, I don't feel it.
Oh, okay. So in extension plus external rotation, you can feel the pain here. So for context, right now, I want to assess the movements where Joseph describes discomfort. Okay, all right. So let's check that. Indicator response. Show me. All right. Let me check if he's here. Okay. Yes, Joseph.
Yeah, I'm just getting the glare out of the room. There we go. Okay, so the other motion was the Politan squat.
Okay.
So I'm going to do left leg first as a reference. So here's my left leg. And then here's my right leg. And right there's where it hurts. And so that just
right.
that just stemmed it.
Okay. So let me check my indicator right there. This is no, still no response with that. Is this limbic physiology structure? Check my indicator again here. Right, a bit. Okay, I think my indicator looks to have. I need to establish my indicator again right here.
You broke up for a second. I didn't hear that, Alan. Can you repeat that, please?
Yes, I was saying I need to establish contact with my indicator again, right there. Right, a bit. Yep. Okay. Right. My indicator seems to have gone off for me here.
Okay, so do you want to explain what you're doing there? Because people don't know what you're doing, that you're cleaning your own slate, resetting your nervous system. You need to, yeah, that's an important piece.
Yeah, right.
So what Alan's doing
now,
is Alan got a confusing result. And so he had to clear his own nervous system so he could start over again to get something that's more accurate.
Yeah, definitely. So as I was using my indicator stopped responding appropriately. So I probably there was an overwhelm in my nervous system as I was doing this. So what I did is what I tried to do is try to tone down my entire nervous system. So using Betty Patton and then K27 point here.
K27 inability. It's also known as green buttons. And it's basically a general tonic for the nervous system.
Yeah, right. So I will rock a bit here. I can take a few breaths. Okay, right. Yeah, looks like I'm back. I'm back. Yeah.
Do you want me to restem? You want me to restem the movement now?
Yeah. Let's start with one for the fibula back.
Fibula back?
Yes. Right, good. Right. So let me check nervous system response to that. Still not responsive. Is this limbic, physiology, structure? Right. Okay. Now the one the squat, the quarter squat you're doing.
I'm just going to do the right leg.
Yes.
And
Right.
there's the stem.
Right. Let me check my indicator response.
Yeah.
Show me now.
I can only go through about a third of the range of motion with my right knee than I can with my left.
Right. Not responsive. Is this limbic, physiology, structure? Right. That's okay. Which other movement did you want to try?
I'm sorry, what were you asking, Alan?
Which other movement do you want to try
What other
apart from
movement?
those two? Yes. How about a deep squat? A squat. Okay.
I was going to say, anytime my knee goes beyond 90 degrees of flexion in a squat, it's a challenge. If there's a
right.
rotational component like a curtsy squat, that's a challenge. But yeah, I can do. I can come here and do a squat like this, right? And so I'm supporting myself so I can load my structure. So that would be using my quadriceps. And if I did a forward leaning squat, I'm more on my glutes. And I can feel the stem right now in this position on my right knee. Here, let me turn.
All right. So
Right. And
show
so just,
me.
yeah.
Okay. All right. So let me check my indicator response with that. Yeah, basically, I'm not feeling getting a response. Not semi-responsive. Then is this limbic, physiology, structure? Right. Okay. All right. That's okay. Calibrate my indicator again. Okay. All right. All right. Yeah. So I'm getting structural correlation for these movements. The one is
Great.
done.
Now,
Right. That's okay.
there's a couple of those kinds of squats that we can look at. Let's look at a kickstand squat. We can look at a short right there in that close when I'm in that going in that closed position. That's tender. Where I've got full range on left leg, right leg I don't.
Okay. All right. Yeah, basically locked. My indicator is not responding to that. Is this limbic? Yeah, is this limbic? Physiology? Right. Is that this limbic physiology structure? Okay, all right, that's okay. And now, after establishing my my assessment map, next thing I'm going to ask, since I'm getting structure, I'm going to ask, is this safe to proceed with this? Right, that's okay.
That would be a really important step, people. What Alan just asked is this safe to proceed? Right? Because there are definitely times when the nervous system will not feel safe, even though Within the patient's
camera-
mind and their consciousness, they want to proceed, but their nervous system has a different agenda or a different need of safety.
Right. Joseph, are you able to raise your camera a bit up, just above your head? You're right, there, yes. So you are describing the aspect of asking is this safe to proceed? Yeah. Maybe if you can do it again, explain it again.
You want me to explain that again?
Yeah.
So when we start talking about safety of the nervous system, there's two things that are happening. One is the perceived safety of the individual, where their mind and their consciousness, they want to proceed. But it's another aspect is the safety of the nervous system itself that is operating at a non-conscious level. And the nervous system can have different needs and different priorities than the mental mind does. And so consent is often thought about as this conscious mind consent, but we're talking about the consent of the nervous system at a non-conscious level. And this is very,
Yes.
very important because the nervous system has its own unique hierarchy of how it is keeping itself safe and how it's maintaining that container of safety.
Yes, right. Right. Now for all the movements we've assessed, our indicator response, and then our correlation was structural. Most of them were actually all of them were giving me a structural correlation. Now, my next job is to find where this problem is in his body. I would ask if it is safe, and yes, it is safe to continue. Yeah, is it safe? Right. So, and then I find where this in his body. If we look at structure, there's so much we can look at in the body, structure-wise. So I'm going to try to narrow down to zone the body to try to find where this is coming from his body. So I'm going to ask: is this is the structure problem on the anterior aspect of Joseph's body? Is this on the posterior aspect? To find out where I should be getting to. Is it on the anterior aspect or posterior aspect? Because the problem could be on the anterior aspect of the body, or it could be on the posterior aspect. Then once I find that,
what I'm just talking about is creating a funnel to start at a very broad viewpoint to narrow to get to specific. And so we start, is it back of the body? Is it front of the body? Is it top, up above? Is it below? And then we can even go to very more specific, because we know that the patient, me, sprained the posterior cruciate ligament. That's probably going to be the primary. Probably. But we want to eliminate other possibilities first before we go right to it. It's kind of like this idea of here's the problem in the center of the circle. We kind of want to go all the way around before we go right to the center because it helps build the map for the nervous system instead of just going right to it. And then there might be other fragments that don't get pulled along. Sorry
yes,
about
right.
that.
Right, that's okay. Yeah, right. So
it's supposed to be out of the way.
Yeah. Thank you for your insight. So, sorry, let me get my indicator back. Right, skin receptor. Good, I think my indicator is clear. So, is the problem on the anterior aspect of his body, posterior aspect, right? I'm getting on the posterior aspect of his body. So something on the posterior aspect. So how I like to work, if something is on the posterior aspect, then I look at the posterior aspect of the body, then I like moving joint by joint or segment by segment. So if you look at the posterior aspect, so I want to ask, is this posterior aspect, I can start from top to bottom or bottom top anywhere. Let me start from bottom to top, going upwards. Say, in this posterior aspect, ankles and feet. So my indicator is this posterior aspect, ankles and feet? No. Is this posterior aspect, knees? Is this posterior aspect, hip joints? Is this posterior aspect something in the pelvis? Is this posterior aspect something in the, so moving upwards, is this posterior aspect something in the spine, in the rib cage, in the, I actually include also shoulder girdle, upper limbs, just to give you the picture of the entire picture of how I spread out my question. Is this cranium? No. Is this I come back to, is this in the knee? Right. Right. So I'm getting a yes for the knee posterior aspect.
Yeah, it's local to the knee.
Yeah. So that's, yeah. So I got a yes for the knee posterior aspect, and then yeah, right. And so if I think about the knee, I want to ask questions about the knee now to try to still narrow down my funnel to what exactly I should be working on. Is this a problem with joint capsule of the knee? Is this a problem with one of the ligaments in the knee? Yes, I'm getting a yes for the ligaments. Yeah, narrowing down joints and then ligaments in the knee, right? So if I know this is so is this a ligament problem on the posterior aspect of the knee? Right, I'm getting a yes for that. Now, so now I want to find which of the ligaments is the primary.
I can therapy localize in the clear for you, or you can use limbic resonance.
Yes, yeah. Let me use limbic resonance. So in the brief, we can do we can find what the problem is by using most of us know therapy localization. Just touching the area we think the problem is, but also we can therapy localize using limbic resonance. Just putting my attention to what I want to ask about. Yeah, connecting with my intention to that area using limbic resonance without touching directly. So I can still do the same, get the same outcome. That is using limbic resonance.
Do you understand what Alan is talking about? He's using intention to project his mind as a form of therapy localization. That's what limbic resonance is. Our power of thought affects the outcome. This is part of quantum mechanics.
Yes, right. So since the problem is showing me something, or maybe a ligament on the posterior aspect of his knee, so the ligaments, I'm going to run through the ligaments, then I see which one is the primary for me, then find its main pair, its main secondary, and then pair those two. So let's find the primary. I want to ask, is this is the posterior cruciate the primary in this case? Okay. I'm getting a no for posterior cruciate. My indicator, getting a no. Is the okay? Is the okay? Is the oblique popliteal ligament at the back of the knee? Is the oblique popliteal the primary in this case? Getting a no. Is the arcuate popliteal the primary in this case? I'm getting a yes for the arcuate popliteal.
On the which?
Is the a arcuate popliteal ligament.
Oh. Okay. What's happening
right
in
from the fibula
the
head.
distal patella tendon?
Yes, come again.
What's occurring in the distal patella tendon?
Oh, okay. Let me ask about that. Okay, right. But is this in the patella tendon? Okay, I'm still getting another with that patella ligament. Yeah, patella tendon ligament. No, I'm still getting a no with that one still. Let me ask about medial collateral, collateral. No, I'm not getting a primary with those ones. Okay, it's here. Yeah, right. Yes, hello.
So we're at the anterior cruciate ligament as the primary?
Yeah, I asked, but I still didn't get it. Mid anterior cruciate, no. Posterior cruciate, no, didn't get it. Didn't come there. The popliteal, no. Popliteal, yeah. I'm getting a yes for the ligament running from the fibula to the posterior aspect. The fibula head into the posterior aspect, yeah. The arcuate popliteal ligament. I'm getting a yes for that.
Talking about at the head of the fibula.
Yes, running backwards. I'm getting a yes for that one. So yeah, from the fibula head.
I've got it therapy localized.
Yeah, sublocalized, let's see, nervous system response, zeta. Right. Yeah, I'm getting, so is that the primary? Right. It's like I'm getting this as the primary.
Okay.
Yeah, this one is showing up as a primary for me.
Okay.
Right. Let me see. Okay.
Then
Let me look for
secondary. I'm gonna stem it. I've got it stemmed so you can find this secondary.
Yes. Let me find this main secondary. So is the main secondary on the is the patella ligament tendon the main secondary? Is the medial collateral main secondary? Is the lateral collateral main secondary? I think no with that. Is the oblique popliteal main secondary? Right? Is the anterior cruciate main secondary here? Posterior cruciate main secondary? No. Is the oblique popliteal main secondary? I'm getting yes for that.
Yes.
Okay, right.
Lateral
Yes,
or
I'm
medial?
getting a yes for.
I mean, lateral medial attachment of it.
Yeah, yes. I'm getting that still. I'm getting that still.
There it is, right there. I got it.
Okay,
I've got the lateral head, and I've got the lateral head of the fibular ligament.
Yes, yes, yes. Okay, yeah, definitely, yeah. That laterally, yeah, it's lateral then posterior. Then how about where you holding with your left hand?
My
Is
left
it
hand,
at the back of?
I'm holding the tibial side of the oblique ligament on the
Yes, yes,
on the femur behind the knee, behind
right.
the knee.
Ah, right. So this is the pairing I've got, and then I want to ask, is this the right pair? Is this the right? Yes, right there, right there. So I want to ask, is this the right pairing I need to do for this case? I'm getting guess for that. Is this pairing a priority to treat? So I'm asking for whether this is a priority to treat. I'm getting clear, yes. Is this safe to treat? Right. I'm getting a yes for this. So yeah, Joseph is going to hold those two areas. So normally what I love to do, if I'm holding these two areas, I wait until there is a pulsing
Yeah.
in, in both of my fingers. Like pulsing,
Oh, cool.
that finger will be pulsing in both of the fingers. So let me have Joseph hold there until he's ready. Okay, so looks like he's ready. Then we can do a DTR. Ah, Joseph, are you able to do a DTR with that? Yes.
That's definitely better.
Ah, right. I was asking something.
I think I missed what you asked, Alan.
Yeah, I was asking. I think we missed the DTR.
What did
Sorry,
we miss?
the deep tendon reflex.
I'm so sorry. I can't understand what you're saying.
Oh, sorry, the deep tendon reflex.
I still don't understand what you're saying. Can you say it slower?
Hey, DTR, deep tendon reflex.
Oh, right. Now there's a lot of different ways of doing that. Do you have a particular way you want me
Ah,
to?
okay.
I can do it this way.
Yes, yes.
I can also do the eye reflex. There's the jaw.
Oh,
Yeah, there's a lot of different ways that you can do a DTR.
okay.
Now, what I'll do when I work with people remotely is I will ask them to take a big breath in and exhale sharply.
All right.
And then what you're doing is you're using the diaphragm to act on the diaphragmatic ligaments.
Ah, right. That's okay. So, so can we check the movements again to see how they are?
Okay, so we'll go to knee extension,
Okay, right. Checking my
knee
indicator here.
flexion. Knee flexion feels a lot better.
Right, that's a yes. How about how is knee extension?
Extension feels good.
Yeah, okay, I'm getting a yes on my indicator. How is
Okay, now
rotation?
let's look at external tibia rotation.
Yeah, that one.
I have more
Yeah,
extension in my knee, it feels
yeah,
like.
I'm getting a yes. No more response on my indicator.
Yep, let's look at some of the squats.
Huh. That looks much better. How is that for you?
Much better. Then
Yeah,
we'll
definitely. That's much better
I'll
right
look at
there.
jaw.
No more response.
This is the one that's super challenging.
Yeah, let's check out that one. You see?
There's still some discomfort, but I
Ah,
have more range of motion. Look at that.
yeah, definitely. Yeah, good, right. Yeah, feels much
It's
deeper.
improving.
Better with that one.
That's greatly improved. I'd say I'm about 80%. And some of it
Yeah,
could be
right.
localized muscular strength because of just atrophy.
Um, your face is still down. If you can raise your camera a little bit. Yeah, slightly above your head. Yeah, right. That's okay. That's okay. Right, that's okay. So after doing this, I love um, I love teaching them joint flossing for the knee.
Joint flossing for the knee? Yeah.
Yes.
Yeah.
To is it to reinforce how do you explain that?
How do I say what we're reinforcing? Well, we're reinforcing um, not only safety for the nervous system with the joint flossing, but we're also reinforcing localized neuromuscular recruitment. And
Yes,
so,
right, right.
yeah, and we're bringing circulation and lubrication to the
Yes,
joint capsule. Um, but I think the main thing is for the nervous system to recognize that a range of motion is safe so that it will more readily go into that range of motion rather than moving away from it as a strategy of aversion. And that's primarily, other than the structural adaptations, for the nervous system, that is the primary aspect of joint flossing is the safety and the recognizing that it is an available motor component when designing movement.
Yes, right.
Did you like that explanation?
Yes, yes, I like it. I normally do this with my patients.
Yeah, I really I think the idea of motor component theory needs to be evaluated more in this process. And the reason why is we don't have conscious volition over how we choose to organize from the cerebellum issuing out motor instructions. And so if the cerebellum is recognizing a component that elevates a safety response, a hypertonic response, it's going to remove that component from the equation. And this is all happening, automatically without volition. We don't have awareness of it. And so when we're working with our joint flossing, we're initiating those responses for the cerebellum so the cerebellum has the opportunity to recognize that it's safe and available so that it can add it into the equation.
Yes, right. Right.
That was a great session, Alan. I was really
Yeah.
surprised at that. That's why I wasn't getting results. It's because I completely missed the fibula.
Yeah. And I haven't done any remote sessions at all. This is like my first remote session.
Good.
Yeah.
Is there anything else you want to share about that process from your perspective for listeners?
Yeah. So for me, what I get from this process is that it's a huge learning experience for me because it allows me to connect to first of all, yeah, my logic plus also my intuitive. It allows me to grow both. And if we sorry, that's about it's about the remote work I did. But with the DNA process, for me, it stands out well because it helps zero down on someone's problem without overstimulating them. Yeah, that's a good for me because it's simple and gentle. I don't have to overwork, over treat them, and it also allows me to help my patient, really get this awareness of the movements that they were not aware of. So someone's able to know, oh, well, I can't move my knee, but right, there's this particular movement that I can't get into. So so with a movement assessment, it allows me to show them show them their movement potential. So they can find the movements they cannot do well, and then it's funny. It's like something surprising for them because as a physiotherapist, I think physical therapy doesn't have the movement vocabulary that you share. Yeah, so most of my patients have done physical therapy, and it's the same stuff. So when they come to me, I begin giving them an exploration of movement potential, movement. So it's a surprising learning experience for them too. It's something they appreciate. That's one of the things about the DNA. And then of course the correctives, the process itself of how we can zero down to whether it is a limbic problem, it is something to do with physiology, it is something to do with structure. I think it is unique. I haven't seen anyone teaching how to do that in a way that honors the nervous system, a coping strategy, and working in a safe way. I think that's something unique to this process.
Yeah, I would agree with that 100%. And it's really interesting because in applied kinesiology, they do have that triad. However, they still focus on structure.
Yes. Right.
And and my thought around that is that structure is more tangible. And so so you're using that tangible benchmark. But if you get lost in the tangible benchmark, instead of it just being a data point, that's misleading, and you can get lost from that. And so this is part of the reason why we want to have multiple data points. Because if we just rely on one data point and it just so happens that it's a data point in what they call another fractal, meaning that there's different layers of our experience, and each layer is considered a fractal. You got to be in the right fractal to make the change that you're looking for. And so you got to have multiple data points to get us into what the right fractal is. And that's essentially the theory behind getting to the common denominator in mapping.
Yes, right. Yeah, that's interesting. And I've been talking to different practitioners. I think some have the idea, but I think there's always an assumption among practitioners on what they should be treating. Without going through the entire assessment process to find what's the priority problem we should be working with. So the people I've been talking to, I think they always get frustrated because it is easy to think that this problem is a limbic association as a priority, yet it's not. Or maybe it's something to do with physiology, yet it's not. Yeah, so like you said, this process helps us get into the right environment.
Yeah. This is one of the things that that Beth put in a really beautiful perspective. And she called it as the funneling process of finding the right neighborhood, the right house, finding the right room, and basically just, creating that funnel to get to what that individual needs specifically, rather than I found a problem, let's get that problem functioning again which may not have any relationship to the symptoms. And so you spend all this
Yes, right.
time bringing function to something that actually isn't going to make meaningful change to the nervous system.
Yes, right. I think there was something in the chat here. Was there something in the chat? Ah, okay, all right.
Yeah.
Yeah, I think that's
Well,
something.
good. Um, I think we should stop the recording now.
Okay. Okay.
Well done.